Good afternoon, everyone. My name is Brittany Starks, and I'm Communications Director for Debbie's Dream Foundation. Thank you all for joining us today. Before we begin, I'd like to take a moment to thank our sponsors for today's program. Amgen, Daiichi Sankyo, Merck, Bristol Myers Squibb, and Seagen. During today's webinar, you can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions after the presentation as time allows. I will now introduce today's moderator and speaker, Dr. David August. Dr. David August is a surgical oncologist and associate director for faculty affairs at Rutgers Cancer Institute of New Jersey. Since his training as a resident at Yale and as a fellow at the National Cancer Institute in Bethesda, Maryland, Dr. August has had a strong interest in cancers of the esophagus, stomach, pancreas, colorectum, and retroperitoneum. He also pursued clinical and research interest in nutrition and cancer prevention and the treatment of advanced esophageal and pancreatic cancers. Some of his long-standing research is focused on using food-based agents to prevent cancer and on the use of vaccine therapies for pancreatic cancer. Dr. August has experience and expertise in surgery for the esophageal cancer, Whipple procedures, and other surgeries for pancreas and rectal cancer. He works closely with a team of genetic counselors to evaluate and advise patients with a strong personal risk of gastrointestinal tract cancers because of a family or personal history. He is the author or co-author of more than 90 publications as the past president of the American Society for the Peritoneal and Nutrition. He serves on the editorial board and peer review groups for many professional journals. Dr. August, welcome, and thank you so much for being with us today.
Thank you, Brittany, and want to also thank Debbie's Dream Foundation for giving us the opportunity to put together this webinar, for supporting us to be able to do it. Gastric cancer is an important issue for all of us on this webinar, and to have this opportunity to meet with all of you today is really an honor and a pleasure. And I can't speak for the other speakers, but during my talk, we'll even try to have a little bit of fun. So we are all members of the Rutgers Cancer Institute in New Jersey, the only National Cancer Institute designated cancer center in the state of New Jersey. And that really assures that all of us not only are active in taking care of patients with gastrointestinal cancers, particularly gastric cancer, but also says that we're involved with the research behind doing a better job in the future so that we can help future patients either avoid getting cancers or having them treated more successfully and less invasively. So I would like to welcome all of you to the webinar. I'll say good afternoon since we're on Eastern time. And for those of you who are further west, good morning. Glad you could all join us. The first speaker in our group today will be Dr. Matthew Deek. Dr. Deek is a radiation oncologist. I had the privilege of helping with his medical school education. He was here at Rutgers, went on to do training at an excellent program at Johns Hopkins, and I was just speaking with his department chair yesterday, and while he was still in the middle of his training, he was targeted to be recruited back here. Been here for, I think, a little over a year now, and has really had an impact on our program. So Matthew, we're very pleased to have you as one of our team members and look forward to hearing your talk, The Role of Radiation Therapy, Who is it for? Matthew?
I think you might be mute, Matthew. You might want to unmute.
Can you hear me okay?
Yes.
That's good.
Okay. Thank you, Dr. August. That was a very, very kind introduction on your part. And as Dr. August said, I'm going to talk a little bit about radiation therapy. And Brittany, do I have control of the slides?
Yes, as soon as you click around, you should.
Okay, I think I'm clicking and it is not moving. Okay, there we go. I'm going to talk a little bit about radiation therapy and gastric cancer. And I wanted my talk to sort of focus on two parts. The first part is just a little bit of background about radiation itself, because I often feel that when someone comes to see me in my office, unlike a surgeon or a medical oncologist, radiation is a little bit of a black box to patients. And it's not the first thing they think of when they think about cancer treatment. And so I think having a little bit of background in exactly what is radiation can give a little bit of insight into exactly how is it efficacious and how can we use it in patients to help them. And then in the second part of the talk, I want to transition over to talking a bit about specifically how can we use radiation in gastric cancer to help our patients. So just very briefly, what is radiation? So actually radiation is kind of all around us all the time, and many things that you wouldn't even think is radiation actually is a form of radiation. So here you can see all the different types of waves that we interact with on a daily basis, and many of them might seem very familiar to you, like a radio wave or a microwave. So when you're listening to the radio in the car or you're heating up your dinner, those are actually a form of radiation technically. That's not the kind of radiation we use in our clinic though, because those forms of radiation are not harmful to us. When we interact with radio waves, when we interact with microwaves or visible light, as you can see here, those radiation waveforms don't injure our body. But as you go from the left to the right on this screen, the energy of the radiation can increase. And when the energy of the radiation can increase, that's when you can start to have changes to your cells. And so you might notice ultraviolet radiation. That's the type of radiation that comes from the sun. And if someone goes to a tanning bed, they'll get ultraviolet radiation, and that can change the skin color by giving you a tan. And if you keep increasing that energy, then you can get in the radiation spectrum of waves that can actually damage a cell. And we take advantage of that in radiation therapy to target cancer cells and damage cancer cells while keeping the normal tissues around the cancer cells healthy. And in our clinic, we mostly use X-rays, which are similar X-rays to what you get with a chest X-ray. And that's the form of radiation that's most commonly used to treat cancers around the world. So when do we use X-rays? We use X-rays in things that you commonly think about, like an X-ray of your chest if you have a cold, or if you need something more complex, you can get a CT scan that gives us even better visualization of your anatomy. Things like mammograms can also use X-rays to look inside the body. And so we use X-rays often on a daily basis, or not on a very frequent basis, to get pictures of our anatomy and help make diagnoses. Now even within the spectrum of X-rays that I showed you on the prior slide, there's a spectrum of X-ray energy within the X-rays we use for medicine. And on the lower end of that energy are things like this, our plain X-rays, our CT scans, and our mammograms. As you start to fine tune and increase that energy a little bit more, that's when we start to get to quote unquote therapeutic X-rays. And that's the type of radiation therapy we use or take advantage of that can damage cancer cells while keeping our normal cells healthy. How does this happen? What happens is the X-rays come into our body and they hit the DNA of the cancer cells and damage the DNA of the cancer cells. And when you get damage to the DNA of the cancer cells, then those cancer cells can't repair itself. However, our normal body, our normal tissue that surrounds surrounds the cancer tissue has properties about it. The cells have properties about it that can repair the damage from radiation, while a cancer cell cannot. And that is inherently the way that we're able to take advantage of radiation, that when a cancer cell is hit with radiation, it's damaged and it can't repair itself. But a normal cell, when it's hit with radiation, it can get some damage, which we'll talk about later, but it is able to repair itself. So when it comes to radiation, there's actually many different steps that we take in order to get a patient ready to receive radiation treatments. The first step is something called a simulation scan, otherwise also called a planning session. And the idea behind a simulation scan or a planning session is that we have to carefully construct a radiation plan that is specific to the anatomy of the individual, because everyone's very different. So we have to come up with a tailored plan that's going to target the tumor and avoid any of the normal healthy tissue surrounding the tumor. And in order to do this, we do our simulation scan. We have to make sure that we set you up every day in a position for radiation that's reproducible. And that's where the word simulation comes from, that we're simulating the actual day of treatment and doing a dry run to make sure that we can do everything safely. So the patient comes into the department, they have a special mold that's made for them that conforms specifically to their body. And once in that mold, the patient will then have a CT scan done in the treatment position, and using that CAT scan, we'll then plan the radiation by physically going in and slice by slice, drawing out where the tumor is and drawing out all of the healthy organs so that we can come up with a radiation plan that targets the tumor and spares the healthy organs. About a week after your simulation is when you'll move on to your treatments. Here's a picture of a simulation scan, a patient undergoing a simulation scan. And as you can see, we have radiation therapists in conjunction with nurses and physicians who come and help to set the patient up in the treatment position. So you can see the white mold underneath the patient's arms, which is almost like a bean bag, where the air will get sucked out and then it will conform to the patient's arms, so that every day when the patient comes in for treatment, they'll just lay down in the mold that's specifically made for them and can have the radiation accurately delivered to the tumor. Once the mold is made, we do some other special techniques and other special scans in order to take into account some other things. For example, when you're breathing, you notice that your abdomen or your skin will move up and down. And that's because as the air is moving in and out of your lungs, things are shifting. And if we don't take things like that into account with the radiation, we won't accurately be able to target the tumor. And during the simulation scan, we'll also do a special type of CAT scan called a 4-dimensional CAT scan, where we're able to take into account all the different phases of your breathing so that we can create a radiation plan that is really anatomically constructed specifically for the patient, each individual patient. Once we have that scan done, like I mentioned, we will then on every slice physically draw out all the different structures that we want to target with the radiation. Once we have all of these structures drawn out, including the tumor and the stomach and the liver and the kidneys and the spinal cord, we're able to use highly advanced software that creates a radiation plan that's tailored to each individual patient. And what you can actually see here in these slides are an example of a radiation plan that's tailored for a patient with gastric cancer. The different colors that you see here on the slide represents different doses of radiation. And what you can see is that with our highly conformal radiation techniques that have been developed over the past 10 years, we're able to do a really good job of targeting a tumor, but staying away from a lot of the normal organs. So what you can see here is that here is a patient's liver, and here is where the tumor is located in this red high dose region, and we're able to deliver a large amount of radiation to the area of the tumor while we're staying off of the normal liver tissue in this patient. When the patient comes in for treatment, the treatment machine looks very much like a CAT scan. The only difference is that instead of it being a donut type shape when you go through a CAT scan, the radiation treatment machine is more open. At the top of the radiation, you can see what's called the gantry, and the radiation will generate from the back of the machine and be sent down through this linac into the gantry, and then come out of the top of the gantry and be shaped towards the patient. The radiation linear accelerator, or LINAC, will rotate around the patient as the radiation is being delivered. And as this machine is rotating around the patient, pieces of metal within the top of the head of the machine will move to different positions, and that's how we're able to shape the radiation in such a precise manner in order to deliver a plan that's highly conformal and specific for each individual patient. What you might notice here is that this patient laying down on the table has a very similar mold around their arms like the patient had at simulation. And as I mentioned, that's the point of the simulation scan, that we're planning the actual day of radiation and taking everything we did at that simulation scan and moving it over to the day of treatment and using it when we're actually delivering the radiation. What should you expect when you're being treated with radiation for gastric cancer? I would say for the most part, treatment is fairly well tolerated by most patients. But of course, there will always be some side effects of any treatment that you undergo. If you remember that slide I showed a couple of slides ago where it showed the radiation going to the tumor, but a little bit of radiation going to the normal structures, oftentimes it's this little bit of radiation, lower dose of radiation that you can see on the outskirts that goes to some of the other different tissues that causes some of the side effects to develop. What are these common side effects? Well, the most common side effect that someone might feel when they're undergoing radiation for gastric cancer is feeling tired. That often manifests itself as wanting to go to bed earlier, sleep in later, taking a nap during the day. However, most patients can often go about most of their daily business each day with little impact, but everyone does get affected differently. Other common side effects that you can experience during radiation is a little bit of an upset stomach or nausea. That's because we sometimes have to we are targeting the stomach when we're going after the tumor, but often sometimes the surrounding bowel will get a little bit of radiation, and that's what can cause an upset stomach. We have really good medications, anti-nausea medicines, that patients can often take about 20 minutes before treatment, and that does a very good job of preventing the nausea from coming on if a patient does experience it. The third common side effect that people will sometimes feel during a course of radiation is having softer stools, even to the point of having some diarrhea. That's very similar to the nausea that you might feel, in the sense that it's caused by some of the surrounding bowel getting a little bit of radiation. And so patients will sometimes have a couple of bowel movements a day, or soft stool bowel movements a day, as they go through a course of radiation. Oftentimes, these side effects will build up as you go through a course of radiation, so that for the first couple of weeks, you might actually feel nothing. When a patient lays on the table and is receiving radiation, they don't see the x-rays come through, they don't feel anything. It's very similar to a chest x-ray or a CAT scan, since it's the same type of x-rays. However, as some of the radiation dose builds up and you get towards the end of your treatment, that's when some of these side effects will start to come up. The biggest thing to remember for anyone who's ever undergoing radiation for anything is that we are always here to help you get through treatment, and that you shouldn't have to go through treatment with untreated side effects. That's why we're here. That's what we've been trained for. And so we'll keep a very close eye on any patient that's going through a course of radiation to make sure if any side effects come up that we're there to help deal with those, because no patient should have to feel uncomfortable during their treatment. So when exactly do we use radiation when it comes to gastric cancer? Well, there's really three times when we use radiation, and I want to go through each one of them individually. The first is following surgery. So surgery is one of the most important modalities when you're getting treated for gastric cancer. And our skilled surgeons do amazing jobs of getting rid of the cancer cell and curing patients. Sometimes there's some situations where the anatomy makes it difficult to remove all of the cancer. And if a little bit of cancer is not removed and still in the body, we want to make sure that we treat that in order to decrease the chance of the tumor coming back. So that's one of the most common times when we'll use radiation, is after surgery to treat any areas that we're concerned there could be some residual tumor. Sometimes it could also be small microscopic amount of tumor cells that a surgeon can't see with their eye, or even with their eye when they're looking into the patient's body during surgery. In situations like that, we can use radiation after surgery to treat those microscopic tumor cells. The way I like to think about it is that I often think about cancer like a vase. If that vase drops and is cracked, the surgeon can do a great job of picking up all those big pieces to make sure that someone doesn't hurt themselves. But there'll still be a little bit of small pieces of glass left behind, and that's why we come with a broom or a vacuum to come clean that up afterwards. And in many ways, radiation is like that. It's like the vacuum that can clean up some of those small pieces of glass that you can't see easily with your eyes. What's the second time when we use radiation? Well, sometimes surgery is not possible because of how the tumor is involving some other organs. Oftentimes that's called an unresectable tumor. And in the unresectable tumor, we start to think about other treatments that can be used to treat the tumor. If a surgery is not possible, we can often use radiation, oftentimes in combination with chemotherapy or other agents that Dr. Barham will likely talk about, to combine these two together to create a treatment plan to treat a tumor that's not able to be removed by surgery alone. And then finally, what's the third time that we can use radiation? Well, sometimes cancer can cause symptoms such as pain or nausea, vomiting, bleeding, and we can use radiation to palliate these symptoms to make them better. So no patient should have to be in pain or feel nauseous or vomiting all the time or have bleeding from their tumor. And radiation can be used in this situation not to necessarily cure a tumor or make the cancer go away forever, but to make those symptoms better and palliate those symptoms so that a patient can be comfortable as they're getting other treatments. And so we often use radiation to improve pain, to decrease nausea or vomiting, or to stop bleeding from a tumor that's going on inside of the stomach. And so that's the general overview of when we use radiation in order to treat gastric cancers. And so I'd be happy to either take questions now or take questions towards the end after all the other speakers have been able to talk. So thank you for your attention.
Do we have any questions that have come in over the chat, Brittany?
It doesn't appear that we have any questions yet, so.
Okay, so we'll move right along then. And at the end of each talk, we'll see if there are any questions. And then we will all try to be available at the end of the talks to be able to have a group question and answer session if we can be of help. The next speaker is Dr. Lyudmila Barham. She's a medical oncologist here at the Cancer Institute of New Jersey. She did her medical training back in the Ukraine, came over to the United States, did specialty oncology training in Buffalo, and then was actually a faculty member up there before coming to New Jersey. I believe it was about 4 years ago. And she joined our GI cancer group about 3.5 years ago. And again, it's just been a wonderful addition to that program. I'm not sure that there's any of us here who care more about the patients than Dr. Barham does. She's constantly bothering me about my patients, and it's never a bother. When there are problems, when there are issues, things like side effects that come up, kind of urging me to do my job, to take care of them. So it's a pleasure to work with her. She's going to be talking today about clinical trials in chemotherapy and immunotherapy. Luda?
Thank you so much, Dr. August. You're so kind. Hello, everyone. My talk today is going to try to include some of the most promising trials and advances in the treatment of gastric cancer, both in the patients who have their cancer potentially amenable for surgery and those cancers who at the time of diagnosis may not be eligible for surgery quite yet. And Brittany, can I, oh, there it goes, sorry. But in the beginning, I just wanted to have a little overview, a little background on what the clinical trials are, the standard language that we use when we speak about clinical trials, why they're being done. And as we speak about the research in the gastric cancer treatments, we're going to be including those promising targets that have been discovered over the course of that past decades that have brought so much hope to both the patients and physicians that are dealing with gastric cancer. So what is a clinical trial? It's a research study that helps us learn whether a new drug or new medicine, new treatment it works and if is it safe to use for people. It is really the safest and fastest way to find new treatments and ways to improve health. Patients do volunteer, it's not mandatory, they volunteer to participate to help find cure and better treatments and potentially benefit themselves. All new treatments really nowadays must pass through the clinical trials before they are approved by the Food and Drug Administration. And the clinical trials are conducted according to this plan. We call it a protocol. It's published, it's available, the patients can review it. And those protocols have very strict rules as to how it's being conducted and how we manage the patients. And so these rules make sure that the patients who are participating in this study are treated as safely as possible and are being helped as quickly as possible. And so the clinical trial is really being done to improve cure rates in our particular situation for gastric cancer, improve the life expectancy and survival for those patients whose cancer can't be cured, and also improve their quality of life and symptoms and help them live better as they're undergoing treatment. So you may be hearing from your doctors or on the public media that there are phases of clinical trials. So what are those? What those phases, what do they mean? So there's the clinical trials, or each medicine starts in the preclinical phase. So it will be usually in the laboratory where they would study it in the cancer cells and make sure that it's effective just against the cancer cells initially, and then they may study it in the animals. And only after that drug is shown that it is effective against those cancer cells and it is safe in the laboratory, does it get to be moved into the clinic, where it starts in phase 1. And phase 1 trials are usually very small trials and includes patients. A lot of times it may be patients who have gone through many treatments for their particular disease, and there are not that many treatments left. And those phase 1 trials may include patients with many different cancers, not just one disease cancers. And the medicine starts to being administered at a very, very low dose. And the goal of phase 1 trial is just to first make sure that it is safe and find the dose that would be the safest and the patients would feel the best while taking this new medicine. Then once we establish that this medicine is safe to take and the patient's symptoms are being managed well, we know how to manage them, then we move it to phase 2. And phase 2 clinical trial is a larger trial. It may be only done in the patients with a particular disease, such as gastric cancer. And in there, we also evaluate the safety of the drugs. We look at the most common side effects. We make sure that we confirm that the dose that we established in phase 2 is still the correct dose. And we see how effective that treatment is for this particular disease. And if it is showing to be very promising and the patient's benefiting, then the drug is moved into phase 3. And phase 3 trials are usually large trials. They are randomized, which means that half of the patients are assigned to the standard treatment, the approved way of treating the disease, and then the other half is assigned to this new way of treatment. And these trials usually take several years. And based on the outcomes of those trials, when the statistics are being analyzed and we see how patients did compared to the standard way of we treat that disease at that particular stage, then the researchers submit that drug for the review for the FDA. So if we saw that the patients benefited, their disease improved, their life expectancy improved, their quality of life improved, FDA reviews all that information, takes it into account, and it may approve the drug. And so when it approves the drug, then it becomes available in the market. And the phase 4 is essentially just when the drug is available for prescription in the clinic. The data is still being gathered to make sure that for the larger group of population in the real world, that there are no any harmful ways that we are discovering that we may not have discovered. That rarely happens, but sometimes we find things that may be beneficial, even more so in phase 4 post the FDA approval. So this is a daunting picture. I just wanted to show you what has been done in the world of research for gastric cancer over the last several decades. The researchers were very busy trying to find out how this cancer divides and how it develops and how it spreads. What are those ways that cancer learns to propagate in the body? And so this is done so that we can learn the ways to stop the cancer. So all of these dots are the molecules that potentially can make the cancer grow, and that potentially we can use to stop the cancer from growing and kill the cancer cell. And they can be on the cell surface, and we call them receptors or antigens, and they can be inside the cell, and we may call them tyrosine kinases. But all of these are just the ways that we know how the cancer is living. And prior to that, prior to all of these discoveries, we weren't so sure. So the research has come a long way, and it's very promising. But I also want to tell you that all of your treatments that you're receiving, or maybe speaking about with your doctors right now, at some point they had gone through clinical trials and have been proven to be effective and have been approved. So now there are more clinical trials being conducted because we know so much more about how the cancer is developing. So now we're going to move on to, we're going to split this presentation in sort of two halves. Initially, we'll see how we treat the cancer that potentially can be removed by surgery. What are the standard ways, and what's the research that is being done to improve the ways of treating the cancer that is potentially resectable, that can be operated on and removed with surgery. So majority of the cancer of the stomach is being treated by a combination therapy. It turns out that with surgery alone, gastric cancer oftentimes comes back. And it has been, we've learned through the research that if we add the chemotherapy before the surgery and then after surgery, that the patients live longer and they have a higher chance of being cured from the cancer. We use several different chemo regimens, and chemotherapy, which is called FLAT, which has 3 medicines in it, is the most commonly used. Sometimes we use a regimen that is called FOLFOX. Other regimens can come up. All of them are trying to do the same thing, shrink the cancer and make sure that the cells that may have escaped that area from the cancer, from the mass in the stomach, that they can be killed before the surgery happens. And then after the patient's healed from surgery, potentially some of the leftover cancer cells can be killed. But we now hear all around us in social media, on TV, on radio, all about immunotherapy. Immunotherapy really made a huge impact recently. It's here to stay. It is a really promising way of treating cancers of any type. It is a very safe way of treating cancer. And so now we're asking the question, can we add this immunotherapy for treatment of patients whose cancer can be resected? Now, it isn't approved yet, but can we study it so that we can potentially benefit from immunotherapy earlier? And there are many clinical trials that are happening, but I'm just going to show you this. These researchers from Germany that they've been leaders in the field of treating surgical gastric cancer, have conducted this, or still are conducting this trial that is called Dante. And what they're doing is, the design is pretty simple. Really, they randomize their patients in the phase 2. So this is a phase 2 trial. Remember, go back to that cartoon of the phases. And so this is a smaller study, but they randomized their patients to be receiving standard way of chemotherapy before and after surgery, or just adding immunotherapy medicine that is called atezolizumab before and after surgery, and then for the full year. And they presented their initial, so preliminary results in the beginning of this year, and they've shown that it is safe to give immunotherapy. Patients didn't have more side effects than those who did not receive immunotherapy, but they did also show that there was a larger degree of tumor shrinkage, and the surgical outcomes, or the chances of the tumor being removed by surgery completely are higher if you give immunotherapy before the surgery. But what we don't know yet, because it's still too early, is whether the patients live longer and whether the cancer coming back rates are less in those patients who have received the immunotherapy. So there are more clinical trials that are happening now. There's this large clinical trial that's aiming to enroll more than 900 patients, and it will include immunotherapy, just like the previous German study, immunotherapy before and after the chemotherapy. And there are many sites in the US and Canada that are open and enrolling patients. And I want to just point out I'll show you that each clinical trial has this NCT number, and you can find the clinical trial based on the number. There's a website that we go to search for a trial, and you can speak with your doctor and find out if this may be a possibility for you. Now, some of you may have heard about a unique type of cancer, not only gastric cancer, but any cancer that is that can be MSI high or mismatch repair deficient. And we know something really different about these cancers. So this is a traditional cancer with just a lot of tumor cells. that are all looking the same, and these immune cells around them, and these immune cells are really few of them, and they really don't go in. They're not able to penetrate, to go inside of the tumor because of how the tumor is built, and they are very tight, these cells. But mismatch repair cancers have the cells of them have many mutations, thousands of mutations, and that makes them very visible to the immune system, to the immune cells. So they are always surrounded by lymphocytes and all the many different immune cells. And it takes just a little nudge from the immune system to a little nudge from the immunotherapy to the immune system, so that immune system can start fighting this cancer. And so we know from other cancers and from gastric cancer trials that that mismatch repair deficient cancers are very sensitive to immunotherapy. So the question is being now raised now, if the stomach cancer is mismatch repair deficient or MSI high, can those patients avoid chemotherapy? Can they just be treated with immunotherapy and do just as well, and maybe even better? So there's this French study that was presented earlier this year, and Dr. Andre is a leader in the field of using immunotherapy in GI cancer. So what they did is they used only 12 weeks of immunotherapy with 2 drugs. They are called nivolumab and ipilimumab for gastric cancers that are potentially resectable and mismatch repair deficient. And so they gave only immunotherapy, no chemotherapy, for 12 weeks. And then those patients were taken to surgery. And what they have shown is they only had 31 patients, 29 of them went to surgery. In 60%, in 19 of 29 patients, there was no tumor cells left in their surgical specimen. So the tumor went away in the 12 weeks duration of immunotherapy treatment. And so with their 2-year follow-up, those patients who went to surgery, they all remain cancer-free and are living. So there's more trials that are being conducted in that space. We have here at Rutgers, we have a clinical trial that involves immunotherapy treatment preoperatively before surgery for certain gastric cancers, including mismatch repair deficient cancer, but other molecular subtypes. And that involves radiation after the surgery. And this trial is still open and enrolling patients. These are some other studies that are being conducted that aim to treat gastric cancer with mismatch repair deficiency in the operative setting, but also in the advanced setting where surgery is not feasible. So now we're going to switch to the treatment of cancers that cannot be removed by surgery. So either the cancer has spread or it's too large and cannot be removed. How do we look at these cancers in 2022? Well, so even though we have all those targets that we've identified, but we really only divide these cancers when they're diagnosed in the advanced stage, we divide them into 2 groups. We divide them in HER2 negative cancers and HER2 positive cancers. And in 2022, the standard of care for these groups are chemotherapy with immunotherapy. So those cancers that are HER2 negative, they get chemotherapy and immunotherapy together. So chemoimmunotherapy, we call it. Those who have HER2 positive cancers, and HER2 is, there are these whiskers on the surface of the cancer cells that we call antigens or receptors, and they make those cancers attract the medicine that is called Herceptin. So Herceptin is being used together with the chemo and immunotherapy, to fight the cancers that otherwise cannot be removed by surgery. These are really the only two ways that we divide the stomach cancer when they are diagnosed at this stage. So can we use all those targets that we saw that there are so many of them? Can we use them so that we can further subdivide these cancers so that maybe we can individualize a little more the treatment of these cancers? And so this is a picture of how on this right side or the left side, I suppose, it's the way we treat the cancers based on the biomarkers that we know how to use right now. And these are the potential biomarkers. And we can't go over all of them, but we'll go over several. So we'll go over the HER2 that we've already spoken about, but there are more ways of targeting that HER2 and using more modern drugs that are more effective. There's this new target that is called FGFR. So it's the same whisker on the cell, on the surface of the cancer cell, that can be targeted, turns out very effectively, and it's very promising. There is something that is called claudin, and that's a protein that can be targeted, and it's in between the cells. And the multi-kinases are those medicines that can be targeting those mutations inside the cells when we saw them, so many of them. So let's start with the HER2 protein that is on the surface of the cell. We have this trastuzumab medication. We've had it since 2010. It showed at that time that it's improving the patient's survival. Patients live longer. They had better quality of life with this medicine. And so we've been using it in the treatment of gastric cancer and other cancers for now 12 years. Oh, but only 20% of gastric cancers have this protein. Now, Herceptin is very effective, but somehow cancer cells learn how to overcome Herceptin still. And so we're looking to find more treatments against this protein, this HER2 protein. One of the recently approved medicine that is a very unique kind of build is called trastuzumab deruxtecan, TDXD we call it. And so it has two parts to it. These whisker parts is the Herceptin medicine, but here it is attached to the chemotherapy portion. And when this whole construct comes in and enters the cancer cell, because it can attach to these HER2 receptors on the cancer cell, it comes into the cancer cell and it destroys the cell because the chemotherapy falls off of it and it's very toxic to the cell. But it destroys the cell, the cancer cell that's next to it. We call it bystander effect. So it's a medicine that recently was approved, and it is now being used in the third line. So after 2 ways of treatment, only in the third line it's used, it's approved, and it showed that the patients are living longer when they are using that medication compared to the standard way that we can treat the patients in the third line. So after the 2 different treatments have failed. We initially saw that it may cause some pneumonia, but now we know how to treat it thanks to the clinical trials, and we know how to prevent it and treat it and recognize it earlier. So it is a very safe medication nowadays. So now this clinical trial that is called Destiny 4 is trying to move this medication to earlier, the second line, and then another clinical trial that is trying to maybe move it up to the first line. So initially to use this medication right away. But it's in the clinical trials, it's not out there, but we're hoping that we will be able to use this medication sooner. There's a medication against the HER2 that is called tucatinib. It is a pill and we call it a small molecule. It's approved for HER2 positive breast cancer together with Herceptin, and it's very effective in patients who have brain metastases. And now we're trying to see if we can use it in the patients with gastric cancer. It is very well tolerated, and there are several trials. They are named Mountaineer 3 and Mountaineer 2, and we are hoping to be able to use this medication in the gastric cancer patients as well. Now, you know how we talked about the HER2 protein or receptor, the whisker on the cancer cells, that is changed the way we treat the patients with those proteins. Now we've discovered another protein like that. It is very promising. It is called FGFR, and it's the same whisker. It usually is seen in those patients who don't have the HER2 protein mutated. And we know that about 4 to 10% of gastric cancers may rely on this pathway to grow their cancer cells and to grow their blood supply to the cancer cells. So the researchers have developed this medication. It's called bemarituzumab, just like the Herceptin, trastuzumab medication. It attaches to those whiskers on the cancer cells. And in addition to killing the cancer cell, it also brings in the immune system. It calls the immune system to the tumor and causes more killing from the immune system itself. By itself, this medication has showed 18% shrinkage in those patients who otherwise had no standard options of treatment. And together with the chemotherapy in a phase 2 trial that was called FIGHT, it showed that the patients also lived longer, and some of them have lived for a longer time, which meant that the cancer stopped relying on that pathway, and that was very promising. So now I wanted to show you also, this is called, we call this a force fall plot, and when we look at you know, how much percentage the tumor shrunk, some of the patients had 100% of tumor go away. Now, it's only a few patients, but it also is a very small study. And I just am very hopeful that this medication will gain with some positive data in the phase 3, the big study, and then we'll be able to use it for our patients down the road. So these are the trials. They are called Fortitude 101 and Fortitude 102. These are large phase 3 trials that are using chemotherapy plus or minus this new drug bemarituzumab in the treatment of gastric cancer with FGFR mutated pathway in the beginning, so at the time of diagnosis, so in the first line. So we are really holding our hopes up for this medication. So next target, this will be our last target that we'll speak about, is called Claudin. Now, you know, researchers have a very strange way of naming their things, but they get to name their things because they discover them. So Claudin is a protein that isn't seen in very many areas in the body. Most of the Claudin we see in the gastric cancer, in the gastric lining, and its function is to keep the cells in between themselves really tight. It seals the gastric mucosa so that there are no leakage, and so it's really taut. Now the cancer makes these seals kind of porous, and helps the cancer, you know, kind of grow inside of the stomach wall and then mutate and then metastasize. So this protein has become a target for the researchers to see if we can block it so that the cancer can stop growing and spreading. It's said that it's about 40% of gastric cancers have high expression or moderate expression of these of this protein and may potentially benefit from the treatment. The medication that is aiming against this protein is called zolbetuximab. It's a very strange way of naming it, but it is a medication that is very effective. So in combination with chemotherapy, it's more effective than chemotherapy alone, and it also helps patients live longer. This was shown in that FAST trial, and again, this was a small phase 2 trial, and now there are several trials that are phase 3, large trials, and they are accruing also globally. One is called Spotlight, and the other one is called Glow, and we are hoping to see some results soon because they're close to nearing accrual. And the last way of treating cancer that I want to speak about is CAR T therapy. It has been on the news, and it has been very, very much advertised in the hematology or in the cancers of the blood cells. Some of those drugs are already approved for leukemia and lymphoma and myeloma because they're so effective. And CAR T stands for chimeric antigen receptor T cell therapy. And so what it is, it's a way to get the immune system T cells to fight the cancer. So when cancer develops, it's a new tissue to our body. So our immune system does not recognize it because it doesn't have. So it's sort of like a key and a keyhole, and our immune cells just do not see those cancer cells because they don't have the hole to the key on the cancer cells. So we need to teach our immune cells to recognize it. So how do we do that? It's a very complex process, and the clinical trials are now ongoing in the cancer cell space. But like I said, there are some drugs that are already approved for other cancers, so we know that it works and it is very effective. So initially, the patients come in and their blood gets collected, and we take out the T cells from their blood and get the rest of the blood back into the patient. And then this T cell group gets sent into the laboratory, and those T cells are manipulated to insert the gene for the receptor against that particular cancer. So it takes several weeks for those T cells to grow with the new gene. So now they have the gene that can recognize the cancer, that particular cancer. And then they have these receptors, these whiskers. They start growing these whiskers on the surface of these T cells that can now match with the cancer cell, with their keyhole, with the cancer cell keyhole. And as those T cells are growing, they are teaching other T cells. They help the more T cells divide and grow, so they create the whole big, large group of T cells out from the small amount of T cells that are taught to fight this particular cancer. And then the patients get admitted to the hospital. They're given a low-dose chemotherapy, and then these T cells are infused into the patient. And now the patient has his own T cells that are matched against the cancer, because we know which antigen or which protein or which whisker is growing on the cancer cells. So now they're matched perfectly, and these T cells can fight and kill the cancer cell. These are just some clinical trials. These trials are still all phase 1, they're early, and they are using different proteins, different antigens from the gastric cancer to develop these chimeric T cells. And one of the most promising proteins is this claudin that I showed you in the previous slide. This claudin protein that seals the cancer cells in the lining, it showed to be the very promising target to be using to develop these chimeric T cells. There is a clinical trial that is happening. It's open in 17 sites across US. And the patients have to have a high expression of this claudin protein to qualify, otherwise it's just not going to be effective. Here at CINJ, we have another clinical trial that is using a different protein on the cancer cells to develop these CAR T cells. But this is really a novel way of treating cancer, many cancers, not only gastric cancer, a very unique way and very individualized way. So the last question is really, research, is it important, and what are you going to gain by entering a research clinical trial? So you can access latest therapies, the ones that are not yet approved. And as we said, the patients are being monitored very closely. A lot of these clinical trials are being paid for by the pharmaceutical companies, so the cost might be less for your treatment. And of course, there's a chance to help others by participating in these trials. Thank you so much.
Great.
This
Very dense talk, a lot of information. Thank you.
I'm sorry it was overwhelming.
No, it's very, very well done, and really state of the art.
It does look like we had some questions that came in.
There are some questions?
Yes, we had some questions come in. I don't know if Dr. Deek is still on. We had a couple of radiation questions as well. Let me just drop it in the chat.
Well, here, this is for actually Dr. Barham. Does splenectomy affect the response to immunotherapy?
So for the clinical trials, that may affect your candidacy, but it is not an exclusion criteria for the patient to enroll, to try immunotherapy.
See, I'm not seeing the question for Dr. Deek.
So I'll drop it in the chat.
Can peritoneal implants be treated with radiation therapy?
We typically do not. Usually that's something that a surgeon like Dr. Iskander or Dr. August will go after. There are some instances when we do, but for the most part, I would say that mostly that's something that the surgeons help with.
Okay, well, look, we've fallen a little behind here, so let's move on to our next speaker, Dr. Mariam Eskander. Dr. Eskander, I think, started her academic career at Harvard, and did you go to medical school at Northwestern?
Rosalind Franklin, also in Chicago.
What's that?
Also in Chicago, but not Northwestern. Rosalind Franklin.
Okay. And then went on to do her surgical oncology training, specialized after doing her general surgery training back in Boston at Beth Israel, went to Ohio State, where she did her fellowship in surgical oncology, a really wonderful program out there, and picked up some fairly unique skills not only surgically, but in clinical trials work. She had a lifelong interest in cancer treatment disparities, looking at the ways that social factors, economic factors affect the ability to receive the best care available. And she's going to be talking about her first love today, though, advances in surgery for gastric cancer.
Thank you so much for having me. So today I'm going to discuss some advances in the operations we do for gastric cancer, how we do them, and how we manage patients before, during, and after surgery. First, let's talk about how surgery helps us accurately stage gastric cancer. As you may know, we use CAT scans and sometimes PET scans to stage gastric cancer. But now we know that the best way to detect occult metastatic disease, or metastatic disease that's not obvious on scans, is through something called diagnostic laparoscopy and washings. So we perform this pre-treatment staging laparoscopy in the operating room through small incisions. We insufflate the abdomen with gas. We're then able to look around the abdomen for peritoneal disease or carcinomatosis, which looks like little white spots on the lining of the abdomen or the bowel. We then perform washings by inserting saline into different parts of the abdomen and sucking it back up. The pathologist can then detect cancer cells if they're present, which is referred to as positive cytology. We consider positive cytology to be a type of metastatic disease, and up to a quarter of patients with gastric cancer undergoing staging laparoscopy can have this positive peritoneal cytology on washings, and this really affects their treatment plan. So we'll talk later on what we do when there is peritoneal disease or positive cytology. But if there's no sign of metastatic disease, most patients will go on to chemotherapy or a clinical trial, followed by surgery if appropriate. And surgery for gastric cancer depends on where the tumor is. If the tumor is in the top part of the stomach, we typically remove the whole stomach. And if the tumor is in the tail end of the stomach, we can leave some of the top part of the stomach behind. So this is called a total gastrectomy, and this is called a subtotal gastrectomy. And there are several options for putting the remaining intestines back together, but typically for both the total and the subtotal gastrectomy, we'll perform what's called a Roux-en-Y reconstruction, where the small intestine is reconnected to either the esophagus or the remaining part of the stomach, and then the other end of the intestine is hooked up a ways down. So what you eat goes down this top limb on both of these pictures, and the pancreatic and the biliary juices come down the other limb, meeting it downstream. If the whole stomach is removed, we can also create a pouch to mimic the way the stomach was by looping the small intestine on itself. And we can perform these operations using open, laparoscopic, or robotic techniques. We also now understand that a more extensive removal of the regional lymph nodes is helpful. So on the left, you can see the lymph nodes that are right next to the stomach. So these are removed along with the stomach during surgery because they're close to the stomach. This is called a D1 lymphadenectomy. The figure on the right shows a more extensive lymphadenectomy, removing the lymph nodes around the 3 major blood vessels that come off of the aorta. And we know now that removing these lymph nodes, in addition to the ones by the stomach, which is called a D2 lymphadenectomy, is associated with better outcomes. So we have data where patients were followed for about 15 years after surgery that shows that the survival rate at 15 years is higher after D2 lymphadenectomy, and that patients who had a D2 lymphadenectomy had lower rates of local recurrence or the cancer coming back in the same area. Now let's go back to the scenario where on staging laparoscopy, the surgeon finds peritoneal disease or the cytology from the washings is positive for cancer. In the past, this was a situation where a patient could not get an operation and would instead just get definitive chemotherapy. Now, there are some studies that suggest that cytoreduction, which is removing all visible peritoneal disease in the abdomen, followed by something called HIPEC, which is heated intraperitoneal chemotherapy, can improve survival for a select group of patients. So HIPEC enables the infusion of high doses of chemotherapy directly into the abdominal cavity, and this is a place where traditional chemotherapy has not been very effective. The HIPEC procedure involves placing these inflow and outflow catheters into the abdomen that are connected to a machine that adds heated chemotherapy. The machine will then continuously circulate this heated sterile chemotherapy into and out of the abdomen, and then the abdomen is manually shaken to make sure that the chemo reaches all parts of the abdominal cavity. So who can potentially get this therapy? Patients with limited peritoneal disease can be candidates. This means that only a few nodules are found in the abdominal cavity. Patients with positive peritoneal washings can even get repeated HIPEC procedures, which can be done laparoscopically until their washings test negative for cancer. Then they can go on to get a curative gastrectomy. At this time, there's really a limited understanding of which patients should get this therapy, and there are several ongoing randomized clinical trials that will help us understand that. Here's an example of some of the work that is being done on this topic. This is a study from a single institution in Texas that enrolled 20 patients over 3 years. Most patients in this study had visible peritoneal disease, but very small amounts of it, and 6 patients had positive cytology only on washings. Importantly, everyone got some chemotherapy before undergoing cytoreduction and HIPEC. So all of these patients then underwent cytoreduction, which is removal of all visible peritoneal disease, and then HIPEC, which is the infusion of heated chemotherapy into the abdomen. And within 90 days of surgery, although the complication rate was quite high at 70%, there were no deaths, and 50% of people were alive at 16 months after surgery. And from the date of diagnosis of metastatic disease, a large proportion of patients survived a year, 50% survived 2 years, and about 30% survived for 3 years. And this is really promising survival data for this group of patients with metastatic disease. Moving on to how we perform these operations, I want to talk about the robot, which is a tool that we can use and the newest addition to the field of minimally invasive surgery. The first robotic gastrectomies were performed in the early 2000s, and they are increasingly being performed with each year. So how does robotic surgery work? The robot is set up at the patient's bedside here and has 4 arms. One will hold a camera and the rest robotic instruments that go into the patient after the belly has been insufflated with air. There's always a qualified assistant at the patient's bedside who switches the instruments in and out and assists with the operation laparoscopically. Meanwhile, the surgeon sits at a console that's also in the operating room but a few feet away, and the surgeon will look through this eyepiece that transmits what the camera is showing with magnification and in 3D, and the surgeon moves the robot arms through these controllers. Robotic surgery is minimally invasive in that it is performed typically through 5 small incisions. We usually create a C-section incision down low to get the specimen out. The instruments that we can use on the robot are varied. We have graspers, scissors, needle drivers to suture, and instruments that deliver electrocautery so we can cut through tissue. And compared to laparoscopic instruments that are straight and can't move, the robot arm has 7 degrees of freedom and it can move freely like a human hand. It also has built-in tremor filtration technology so that any tremor that the surgeon has can be removed. So how does robotic surgery compare to open surgery? Studies have shown that robotic surgery takes longer, but is associated with less blood loss and a shorter hospital stay. For hospital stay, most studies show a difference of about 2 days. Patients who have robotic surgery require less narcotics after surgery, but most studies show no difference in complications or long-term cancer outcomes. And compared to laparoscopic gastrectomy, one randomized trial did show a lower rate of complications, and patients in that trial passed gas a little less than a day sooner. However, using the robot is more expensive and takes longer, but probably the biggest benefit of the robot is for the surgeon. Surgeons report feeling a reduced workload and less feelings of discomfort when they operate on the robot rather than doing laparoscopy. And again, there are no differences in complications and long-term cancer outcomes. So this is a study that I thought was really interesting that showed data from consecutive patients who underwent robotic gastrectomies for gastric cancer by 5 surgeons at 2 high-volume institutions in China. They were interested in the concept of a learning curve, so the point at which the surgeon has enough experience such that an outcome of interest improves. So these are graphs that show operative time on the y-axis and then the number of cases on the x-axis. And the dotted line shows the inflection point in the curve, or in this case, when the operative time starts to go down. And so panel A here shows the learning curve for robotic distal gastrectomy for all the surgeons. And they found that the operative time starts to go down at about 20 cases. This is for robotic total gastrectomies. And again, the operative time starts to go down at about 20 cases. Then they saw that some surgeons had already done robotic distal gastrectomies before doing total gastrectomies, and they found that their learning curve is faster. They only needed to do 14 cases before their operative time decreased. This is compared to surgeons who didn't do distal gastrectomies before total gastrectomies. And here's the data on complications. So the complication rate is on the y-axis and the number of cases is on the x-axis. And again, here's the learning curve for all surgeons for robotic distal gastrectomies. They needed to do about 23 cases before their complication rate started going down. For total gastrectomy, it's about 18 cases before their complication rates fell. And then again, for surgeons who overcame the learning curve by doing distal gastrectomies before total gastrectomies, it took fewer cases for them compared to the surgeons who didn't. So this study shows that the learning curve for robotic gastrectomy is quite steep. You don't need to do that many cases before getting better. And that overcoming the learning curve doing one type of an operation will help surgeons achieve competence faster for total gastrectomies. Basically, the more operations you do, the faster and safer you get. The last topic I want to talk about is near and dear to my heart. This is enhanced recovery after surgery, which was one of the biggest changes in the field in the last 20 years. Before we had ERAS, there was a lot of variation in how we took care of patients around the time of surgery. And ERAS standardizes how we do things. It's made up of patient-centered, procedure-specific pathways that guide our management of patients before, during, and after surgery to improve the quality of patient care. So in the preoperative period, for example, we focus on preparing patients for surgery by helping folks stop smoking, helping people gain weight, helping them increase their physical activity. We give patients nerve blocks during surgery to reduce the amount of opioids they'll need. And then after surgery, we help patients get out of bed faster to encourage their intestines to start working. We help patients get home faster and focus on helping them get back to their baseline faster. So instituting these principles and protocols really helps patients. It reduces the time that patients spend in the hospital after surgery. It reduces complications, costs, and opioid use. And finally, ERAS is safe. There's no increase in readmission to the hospital or mortality. So I wanted to share with you some of our pathways, our postoperative pathways here at CINJ. The top part of the graph shows the days after surgery, and this part of the chart shows the different expectations or steps to recovery. So as you can see, for a distal gastrectomy, we start people drinking liquids on day 2 and give them a regular diet on day 3. We ask patients to sit in a chair on the day of surgery, and we help patients take walks and help them perform breathing exercises from day 1. And all of this has shown that we can, again, help patients get back to their baseline faster and home faster. So we can get some patients home after a distal gastrectomy, after only 3 days in the hospital. For total gastrectomies, this looks similar, but patients stay in the hospital a bit longer. And so for patients after a total gastrectomy, we will get the tube out of their nose on day 2 and have them start drinking small amounts of liquids on day 3. By day 4, they're transitioned from clear liquids in the morning to a soft diet in the afternoon, and some people can go home on day 5. But again, we get urinary catheters out early, we have patients sit in the chair and take walks early. So here are just a list of takeaways from my talk. Diagnostic laparoscopy and washings are important for staging. D2 lymphadenectomy, which is the more extensive lymph node removal, improves survival. Some patients with limited peritoneal disease or positive washings may be candidates for cytoreduction and HIPEC, which is the heated chemotherapy in the belly. Robotic surgery does not compromise cancer outcomes, so you have the same cancer outcomes whether you're getting a robotic surgery or an open or a laparoscopic surgery. Robotic surgery does have some advantages over open surgery. It has fewer advantages over laparoscopic surgery, and most of the advantages are for the surgeon. Experience matters. And finally, ERAS promotes faster recovery. Thank you so much. I'm happy to take questions.
Thank you, Dr. Iskander. It looks like a couple of questions have come in.
So there was another question on peritoneal radiation therapy and peritoneal carcinomatosis, and that's really the same as the question about radiation therapy and peritoneal implants. You just can't give radiation therapy to the entire abdomen. It causes too many side effects when you do that. So it's really not a treatment for peritoneal carcinomatosis. And then this one is for Dr. Barham. Does immunotherapy or targeted therapy help keep cancer cells that are undetectable in the peritoneal cavity from progressing?
Yes, so we call these treatments systemic therapies, and that is because they circulate in the blood all throughout the body. So this would be really the only therapy that would be effective in those places where we can't detect it with laparoscopy or CAT scans, because all of our organs, every single cell essentially derives food from the blood, and blood circulates throughout the body. It carries all those medications to those sites where the cancer might be hiding. So the question, the answer to this question, yes, it would be.
Okay, since we're running behind, why don't we go on with my presentation, and then after that, we'll have time to catch up on a couple of questions in the chart and take any new questions. I'm sorry, go ahead.
I'm going to give you control of the mouse.
Great. Fine, so I'm going to be talking about gastrectomy. What is the resulting physiology and how will that affect you? There we go. Okay, so physiology is really the branch of biology that deals with normal functions of living things and their parts. So I'm going to be talking about that as a way of also talking about pathophysiology. Pathophysiology is kind of the evil cousin of physiology. It's when things go wrong and when things aren't functioning normally. And that, of course, is something that happens all too often after major abdominal surgery, that things don't quite function the same way. So I'm going to talk a little bit about the physiology as a way of explaining why some things don't go quite as well as you'd like them to after the surgery, and then talk a little bit about the treatment of those problems. Yeah. Brittany, I'm sorry, it just doesn't seem to be advancing. There we go. Okay, so this is a picture of the stomach. Up here is what we call the gastroesophageal junction, the GE junction, where the esophagus and the stomach come together. And there's a valve there called the gastroesophageal sphincter, and that's very important because it prevents reflux. It prevents things from in the stomach going up into the esophagus, and that can cause bad heartburn. And as we'll talk about in a couple of minutes, it can, if bile goes all the way from the intestine up into the esophagus, it can be a huge problem that sometimes only an operation can solve. At the other end of the stomach is what we call the pylorus. That's another sphincter, another valve. And that pylorus is very important because it slows down the emptying of the stomach. And again, as we'll come to, some of the major long-term problems that people experience after gastric surgery is that the stomach doesn't empty properly. It empties either too quickly or too slowly. Now, the most muscular part of the stomach is the antrum, this lower part of the stomach. And when food comes down into the antrum, it stimulates cells in the lining of the antrum and the mucosa of the antrum, called the G cells, to secrete gastrin. And that gastrin goes through the blood system to come back up to the fundus and the body of the stomach, so the biggest part of the stomach. And that gastrin then stimulates the lining cells there, the mucosal cells there, to secrete, to make hydrochloric acid, that's stomach acid, something called intrinsic factor that I'll get back to, and also pepsinogen, which is a digestive enzyme for proteins that begins to work in the stomach. Let me try to move on to the next slide here. There we go. The other piece of normal physiology that I'd just like to point out are the vagus nerves. The vagus nerves come down from the brain and basically go directly to the stomach, giving off some other branches, including to the heart. But because that's a direct connection, your stomach is really talking to your brain all the time. And clearly removing part of the stomach disrupts the way the vagus nerves affect the stomach. And that the vagus nerves really have two major functions in regard to the stomach. First, they stimulate the antrum, the lower part of the stomach, to contract and empty. So if the vagus nerves are disrupted in any way, the stomach may not empty normally. And then I don't know how many of you have remember hearing about Pavlov and his dogs. Pavlov, for a couple of weeks, gave dogs meat and at the same time rang a bell. And the meat caused the dogs to salivate, to drool, and also caused their stomachs to churn. And then he got rid of the meat and just sounded the bell after those couple of weeks of training. And when the dogs heard the bell, they salivated and their stomachs churned. So that these vagus nerves affect our belly the moment we see food and can affect the way that we have hunger and desire to eat. Now, this is very similar to a picture that Dr. Eskander showed. So if you have a tumor in the lower end of the stomach here, that tumor is removed. Sorry about that. There we go. Thank you. So in the lower part of the stomach there, if there's a tumor there, that gets removed, and then the intestine has to get rerouted. And we keep this part of the intestine intact and take the intestine lower down and route it up to the stomach here. So bile and digestive enzymes from the pancreas go here and meet up with the food. If that bile refluxes into the stomach, as long as the gastroesophageal sphincter, the valve up here, stays intact, that bile won't get into the esophagus. Next slide. Now, if the whole stomach needs to be removed because the tumor is higher up, then there is no gastroesophageal junction. And in that situation, we have to do that Roux-en-Y anastomosis connection that Dr. Eskander pointed out. So we take the intestine here, divide it, take this end up to the esophagus so that food can continue to go down all the way through the intestine. And now the digestive enzymes come in further down. And that's important because then the bile and digestive enzymes won't reflux, won't go backwards up all that distance into the esophagus and cause problems. Next slide, please. So when I'm in the office and talk with people about removing the entire stomach, at least half of them say, oh my goodness, how can I live that way? Well, it turns out that really the stomach only has two important functions. It has a reservoir function, and then it has a function in absorbing vitamin B12. Everything else that the stomach does, we really don't need. Next slide. There we go. So when food comes down into the stomach, and this will happen to all of us next week, Thanksgiving, it sits in the stomach so that we can sit down and have a really big meal. And that's one of the reasons we feel quite full after a big meal, because part of that meal is still sitting in our stomach for a while. And in the stomach, it gets churned by the antrum in particular, so that it gets into a more liquid form before it goes through that lower valve, the pylorus, into the intestine. And that reservoir function of the stomach, again, is what lets you eat big meals. And after a gastrectomy, it's much harder to eat big meals. That's why we often tell people to eat 5 or 6 smaller meals during the day. Next slide. The other thing that the stomach makes is intrinsic factor. That's a protein that binds with vitamin B12 that you eat, and that vitamin B12 would otherwise be digested in the intestines, and it wouldn't get into your body. It would be broken down. But by binding with the intrinsic factor, that intrinsic factor protects it until that combined molecule, the intrinsic factor with the B12, can be absorbed further down in the intestine. And then it can get into the body where it can be utilized. Next slide, please. Now, vitamin B12 is quite important because without it, there can be significant nerve damage, including dementia. There can be inflammation and burning in the mouth and the tongue, a variety of problems with pain in the abdominal cavity and muscle weakness. So that a vitamin B12 deficiency can be really quite serious. And it's one of the things that we need to think about after doing a total gastrectomy. Fortunately, that B12, that intrinsic factor rather, is made in the upper part of the stomach. So we can remove 80% of the stomach and there won't be a problem with vitamin B12 absorption. Next slide, please. So, as I said, the biggest problems that we see after gastrectomy in terms of gastrointestinal function have to do with stomach emptying, gastric emptying. And normally, when the stomach fills up, it's stimulated to contract and food will empty. After removing part of the stomach or disrupting the vagus nerves, the stomach may not empty very well. And then food will sit in the stomach for a long time. And that's what we call gastroparesis, or delayed gastric emptying. And that can be a major problem. Next slide, please. The signs and symptoms of that include vomiting, because everything's just sitting in the stomach, and the stomach responds to that by causing you to vomit. Obviously, with that will go nausea. There can be bloating of the abdomen along with pain. One of the really difficult things for many people after stomach surgery is a feeling of fullness, what we call early satiety, after eating just a few bites. There can be acid reflux because that acid is just sitting in the stomach and wants to go somewhere. There can be a lack of appetite, and then weight loss and malnutrition. So delayed gastric emptying can be a significant problem. Next slide, please. Its kind of sister or brother is what we call dumping syndrome, and this is when the stomach empties too quickly. So by removing the bottom part of the stomach and getting rid of the sphincter, the pylorus at the lower end of the stomach, sometimes food will just rush out of the stomach too quickly. And when that food and liquid gets into the small intestine, it causes it to swell up, and that can lead to flushing, kind of like hot flashes. It can lead to low blood pressure. It can cause some people to faint, and also cause abdominal pain, diarrhea, bloating, and nausea. So that there's some overlap in the symptoms between dumping and delayed gastric emptying. Next slide. So again, the symptoms of dumping, particularly problematic, can be the flushing and the diarrhea, and then what we call colic, just cramping. So that these can be really disabling symptoms if the stomach empties too quickly. Next slide, please. So the treatment of gastroparesis, delayed gastric emptying, often involves eating smaller meals more frequently, chewing food thoroughly so that it's more liquidy as it enters the stomach and can leave more easily, eating well-cooked fruits and vegetables rather than raw fruits and vegetables. One of the few times when we suggest to people they not eat fresh fruits and vegetables. Avoiding fibrous fruits and vegetables such as oranges and broccoli, choosing mostly low-fat foods, but if you're able to tolerate the fat, can add small servings to your diet to help get in the calories that you need. And then often things like soup and pureed foods, if they go into the stomach as liquids, they're easier then to leave the stomach and go on to digest. Next slide, please. Important to drink enough water. often gently exercising after you eat. So standing up, getting gravity working, and then going for a walk can be very helpful. Carbonated drinks and alcohol can also affect stomach emptying and should be avoided. Try to avoid lying down while the stomach is full, and that can be for up to 2 to 3 hours after a meal. And then there are also some medications, metoclopramide and erythromycin as well. They help stimulate stomach contractions. And then anti-nausea medications, ondansetron and prochlorperazine. Next slide. On the other side of things, if there's dumping, if the stomach is emptying too quickly, again, eating smaller, more frequent meals, lying down after the meals so that gravity tends not to help emptying the foods, drinking your fluids between, not during meals. Again, anything that you can delay the solid food in the stomach turning into liquid, the slower the stomach will empty. Proteins tend to stay in the stomach longer, as do complex carbohydrates like whole grains and fiber, and limiting high sugar foods. So, stay away from the Halloween candy and sugar and things like that. And again, increased fiber intake can also be helpful. Next slide. And then just a couple of pointers before I finish up, that what I call the male effect, these things tend to be worse in men than in women. And why is that the case? I'm not sure anybody knows for sure, but my hypothesis is that men are just more stubborn than women. And they don't want to believe that they can't eat the way they used to, and just keep trying to eat that way, trying to eat that way. And in half a dozen men, I've seen either dumping syndrome or gastroparesis lead to very serious, almost life-threatening losses of weight because of that. And I've just not seen that in women. Uncontrolled weight loss medically is the most worrisome symptom of these problems, and it can cause long-term health problems. So that while delayed gastric emptying or dumping can be uncomfortable, unpleasant, cause social problems and trying to go out to eat or eating with family, it's when they're accompanied by weight loss that they become even more problematic medically. But fortunately, diet and lifestyle changes, occasionally medications, can reduce these symptoms and make them manageable, return some of the joy of eating. And in general, with these kinds of things, it's important to be patient. Treatment of these problems goes step by step and can take a while to have an effect. Trying one food, one change at a time is most effective. And generally, with that kind of approach, and we are very religious about making sure that any of our patients with these kinds of problems also meet with our dietitian. And with that kind of help, many of these problems will just get better with what we call TOT, tincture of time. Given enough time, generally things get pretty manageable. I'll stop there. Thank you very much.
Thank you, Dr. August. It looks like we have a couple more questions that have come in, and you can filter through them to see who should be asked those questions.
Okay. Let's see. Are patients who have peritoneal recurrences after total gastrectomy potentially candidates for HIPEC? Miriam?
Good question. I think the short answer is maybe. I can tell you that people with peritoneal recurrence are not the group of people that are standardly being studied for CRS and HIPEC. Usually it's patients who have peritoneal disease at the time of getting their gastrectomy, and so they'll get surgery at the same time as treating their limited peritoneal disease. I think my advice in this sort of a situation is to seek treatment at a high volume NCI designated cancer center, because it's at those places where multidisciplinary conferences that kind of look similar to our panel here, where we'll have medical oncologists, radiation oncologists, and surgeons talk together about the best path for patients in that situation. They can also discuss if there are clinical trials available. I can tell you that the things that the multidisciplinary group would consider here are how much time has lapsed between the time of surgery and the time of peritoneal recurrence. If there are any other sites of disease that might make someone not a candidate. The period of, they might require a patient to get back on chemotherapy to demonstrate stability of disease and non-progression of disease. And then I can tell you, based on the studies, again, that are not done in a population of patients with peritoneal recurrence, the PCI, or the peritoneal carcinomatosis index in that group of patients, is very, very low. So in that study that I presented, 75% of patients had a PCI of less than or equal to 2. So it's generally for quite limited disease. And hopefully we'll have more data on that particular question, but right now our understanding is pretty limited.
Thank you. The next question is somewhat related. So for patients with peritoneal metastases who do not qualify for CRS, why don't we just use HIPEC to treat them?
Yeah.
Go ahead.
Yeah, it's a great question. Again, in the studies that we've done, CRS and HIPEC go together. So we need to achieve complete cytoreduction or removal of disease for HIPEC to be effective. And we don't know. We don't have studies that tell us whether HIPEC alone can prevent the spread of peritoneal disease, but that's what clinical trials are for.
Okay, the next question, where did it go? For people with chronic pain who are on opioids and have no stomach, what can they do to help avoid damage to the gut? And this can be a significant problem. The primary problem we see with long-term opioid use in the gut is slow down movement of the gut, so that food doesn't move through as well, and sometimes can be very, very problematic with constipation. There are some drugs that can be used for the constipation. There are non-narcotic pain medications that we're trying to use more and more. And then there are non-medication approaches to pain, which sometimes can be helpful, and will often involve one of our palliative care specialists or one of our pain management specialists with people like that to help see if they're eligible for other approaches that might work better than opioids. And Luda, did you have anything to add to that?
Yeah, I can say that for those patients who are dependent on opiates for pain control and have a side effect of ileus or just very slow gut motility, there are now medications that reverse the effect of the opiates on the gut motility. One of the medicines is called Relistor. There are other that are oral. And they do not eliminate the effect of the pain control. They just work at the area of the gut and the innervation of the gut and remove the effect of the opiates from that. So you may want to discuss that with your doctor. And palliative medicine is a referral is a great idea, and we always encourage that. There's some adjunct adjuvant medications for neuropathic pain that can be very useful and can lower the doses of opiates that patients require. So there's gabapentin, there's Cymbalta. They're very effective for those for the type of pain that is caused by the neuropathic pain.
Great. Also, another question for you, Dr. Barham. Do you know if immunotherapy is effective for patients who had surgery first and then adjuvant FOLFOX with a CRS score of 5? So I think really asking the question, is there any proven role yet for immunotherapy following CRS and HIPEC, debulking, surgical debulking, and then heated intraperitoneal chemotherapy?
I think this is CPS, the tumor proportion score, right? So if the situation is such that the patient had the gastrectomy or subtotal gastrectomy and then postoperative FOLFOX and finished the FOLFOX or was no evidence of disease, that we don't necessarily put the patients on maintenance immunotherapy in that situation. This question maybe is coming from the data in the esophageal cancer. I know that many of you know that immunotherapy is now approved as an adjuvant or consolidation therapy for those patients who had preoperative chemo and radiation for the esophagus cancer and then went through esophagectomy, and they had some leftover tumor on their surgical specimen. So then we do recommend postoperative or adjuvant or consolidative immunotherapy for up to a year. But for the patients who had resected stomach cancer and finished adjuvant FOLFOX, there isn't data that more treatment with no evidence of disease would benefit, even if it's immunotherapy.
Dr. Deek, this is a question that's been addressed before, but maybe you have something to add. Can peritoneal implants be treated with radiation therapy? You're muted.
You were on your phone. I think you had to unmute via your phone. It's not quite unmuted.
Okay. Well, we'll come back to you if we can here.
You have to your pin for the phone, Dr. Deek.
Yeah.
Go back to the audio tab and enter that pin.
You know, I think we've addressed all of these questions. Are there any
radiation oncology questions? There's a question for Dr. Deek. Can radiation be used for bone metastasis?
So can radiation be used for bone metastasis? And the answer to that is yes, that bone metastases can be quite painful, and radiation therapy for the most part is quite effective in treating pain for localized bone metastases. It can't be used if there are multiple bone metastases in many different places. It only treats the spots where the radiation therapy is focused on. But if there's a focused area that's causing pain, radiation therapy can be quite effective.
Sounds like Dr.
Can you hear me now?
Yes.
Yeah.
Yeah, I'm so sorry. I accidentally hung up the phone when I was trying to unmute. But I heard the tail end of what Dr. August said, and I completely agree that there's a focal area that is causing discomfort, or we're worried even that area can become fractured or have a break in the bone because of the tumor eating away at it. We will often offer radiation in those situations.
Matthew, there is another question probably for you about Optune. Are tumor treating fields being considered?
So tumor treating fields, the idea behind tumor treating fields is that you are delivering an alternating magnetic field to the tumor, and the way tumor cells grow is that they divide, and part of the mechanism of their division is that there are these proteins that go to the each end of the dividing cells and pull the cells apart. And these tumor treating fields, the alternating magnetic field actually stun those proteins that pull the cells apart. It's used in some cancers, such as brain cancers or cancers of the lining of the lung, but we don't really have great studies looking at it specifically in stomach cancers, but maybe in the future it'll be looked at.
Looks like that may be the last question. And so, you have something to say, Dr. August?
Yeah, so it looks like that's the last question. I'd like to thank our speakers, Dr. Barham, Dr. Eskander, and Dr. Deek. We're very pleased to have the opportunity to show off our teamwork from here at the Rutgers Cancer Institute in New Jersey. And we're glad that the audience joined us, and hopefully we're able to inform you. Brittany, we very much thank Debbie's Dream Foundation for giving us this opportunity, but also for all of the good work that the organization is doing.
Thank you so much, Dr. August. And we also would like to thank each of you for joining us today, taking time out of your busy schedules to help educate our community. Thank you so much for your time and your wonderful presentations. We'd also like to thank our generous sponsors for helping to make this program possible today. And we'd love to thank our wonderful attendees for joining us today. And we hope that you were informed and that you learned something that can be useful today. So to keep up with all things Debbie's Dream Foundation, please visit our website for some of our upcoming events and programs, such as those that are listed here. And this concludes today's presentation. So thank you so much for your time, and we look forward to you joining us for our next program.
Bye-bye, everyone. Thank you so much.
Thank you.
Bye-bye.